everyone. Good morning, good afternoon, and good night. Thank you so much for joining us today. We are fortunate to have Leslie here with us for this webinar sponsored by the IACH, International Academy for Clinical Hematology. Today's topic is very close to my heart because it addresses a very important clinical problem. We have seen revolution in immunotherapies, most importantly, bispecific antibody therapy across different hematological malignancies. I would say after the CAR T-cell therapy, this is the next front. These therapies are very effective in several types of malignancies, and currently we have several FDA-approved bispecific antibodies in our clinic. However, these therapies are associated with some unique short-term and long-term side effects, and it comes with quite a bit of regulatory burden as well as the requirement for monitoring this patient, mainly for early cytokine release syndrome and neurological toxicities. Originally, when these therapies were studied on a clinical trial, this patient had to go in the hospital, get admitted for anywhere from 7 to 10 days or sometime even longer for just monitoring for these side effects. And as these drugs became available in the clinics and we developed more experience, Vanderbilt and many other centers across the world has started to use this drug in an outpatient setting. Leslie is with us for 20 plus years in oncology. She has lots of experience across different malignancies, and she's our key member in a cellular therapy and immunotherapy clinic here at Nashville, and developing the outpatient bispecific therapy and kind of really setting up all the infrastructure around it. And she'll be sharing her experience with us today about how bispecific therapies can be done safely in an outpatient setting. And if your program is interested in developing such service, what are the tools and trainings are required before one program can launch this thing? So we have roughly 20-25 minutes of talk, followed by plenty of time for question and answer. So please stick around, and Leslie, take it over, please. Thank you so much.
Hi there. Again, my name is Leslie Mader, and I was fortunate enough to work with Kate Kennedy in this outpatient bispecific initiation clinic. We started the clinic late September of 2024. It operates 7 days a week. We had to come up with a schedule of sharing space. So we use our outpatient transplant unit Monday through Friday. Our appointments are scheduled 1 to 3. On Saturday and Sunday, they come in between 11 and 2. This is totally run by our advanced practice providers. The
Leslie,
outpatient.
I don't see your slides.
Okay, it says I am screen sharing. Let's try this one more time. Share. I think I was still in the practice screen. Is it working now? Do you see it now?
Ifrat, are you able to see it? Maybe it's a problem with my... Okay, looks like, yes, somehow it's... Oh, I see. My apologies. Please proceed.
Oh, that's okay. This is completely run by the APPs. The attending is still there attending, but this clinic is run by APPs. On the weekend, we have a Browning team that's part of our inpatient team that sees the patient on the weekend. This is housed again in our outpatient transplant unit. The patients are monitored during their monitoring period through our hospital at home program. They have a virtual RN visit between 10 p.m. and midnight. They must stay within 35 miles of Vanderbilt. We have the American Cancer Society Hope Lodge, or a local residence, or a hotel that we have a lodging coordinator that helps them procure. The attendee coverage, the patient's primary attending will remain their point of contact for issues or support while the patient's being seen in the bispecific clinic. How does this happen? How did we get the order? How does this get initiated? First, everything's physician driven. The physician identifies the patient. They send a message to the pharmacists and the bispecific coordinator. Then there is an expanded review of therapies for certain drugs, which is just a purchasing process that is entered. The pharmacy enters the treatment plan, and that automatically sends a message to the bispecific antibody clinic message basket in our electronic medical record to let me know that a patient's coming through. Me, as the bispecific RN coordinator, I communicate with the patient, I provide the education materials, and schedule all of their appointments. One thing that we found to be very beneficial and very important is the teaching visit with the APP that has to be done prior to the start of the bispecific in the clinic. I help with the lodging. I get everything scheduled for the bispecific clinic. The therapies that we offer in the outpatient setting, we do teclistamab and talquetamab. It's a sub-Q injection. They must stay within 35 miles of Vanderbilt during their ramp up, and we do remote monitoring. They have a hospital at home virtual nurse visit between 10 p.m. and 12 a.m. It's mandatory that they have a caregiver 24 hours a day. We do the ramp up dosing here day 1, 3, and 5. That's our goal, is to do it within 48 hours. So the patient stays cycle 1, day 1, through 48 hours after their last ramp up dose. Epcoritamab is a sub-Q injection. They're per the package insert, they must have a driver 48 hours post-dose. They are not required to stay within Vanderbilt until day 15 for DLBCL or day 22 for follicular lymphoma. We strongly recommend that they have a caregiver for 48 hours post-dose, but it's not mandatory. For day 15 or day 22, it requires a caregiver and overnight monitoring with a virtual RN visit between 10 p.m. and 12 a.m. And one thing that's not mentioned here that's very important with epcoritamab are the post-dose steroids. The patient receives a calendar that they are to take their steroids day 2, 3, and 4. We give them 16 milligrams of steroids that they take in the morning for those days. Glofitamab is a 4-hour infusion. They must have a driver 48 hours post-dose. They are required to stay within 35 miles of Vanderbilt, cycle 1, day 8. And they have a virtual nurse visit between 10 p.m. and 12 a.m. Due to the length of time of the infusion, we had to schedule them a little bit differently. Again, because we shared space in our outpatient transplant unit, we didn't start our visits until 1. Well, this infusion would run us over in the end. So we had a little work through there where we coordinated with our infusion friends, and they took the patient. We did a handoff, and the patient went over to their clinic to finish it. Mosunetuzumab is also a 4-hour infusion. There's no driving for 24 hours post-dose. No post-dose visits are required. Again, due to the length of time, they did the same thing. We saw them in the bispecific clinic, got everything ready to go. They started their infusion, and then I would take them to our infusion clinic to finish up their infusion. Now, Kate came up with a wonderful plan for timing of when we started every drug due to their expected increased risk for CRS and ICANS. Tech and Talc had to start on a Monday. We limited 2 cycle 1 day 1 patients per Monday. This was in the beginning just so we could work through all the kinks. They are seen every weekday by a provider during their ramp up dosing. They had hospital at home remote monitoring, and I'll show you all a picture of that here in one of the next few slides. They have a telehealth, and it's an RN visit only between 10 p.m. and midnight. On the weekends, they were not seen by a provider unless they were being dosed, or if the RN had any reason like to think that there was some CRS or ICANS going on, or if there were any questions or problems, they would page the Browning provider and they would come see the patient. Epcoritamab would start Tuesday, Wednesday, or Thursday. Again, this is decided based on their increased risk for CRS and ICANS. The patients this is a weekly ramp up. The patients are seen by the APP on the days the drug is due. They do not require post-dose visits except on, again, day 15 for DLBCL or day 22 for follicular lymphoma. They will stay locally and they'll have hospital at home monitoring. Caregiver is strongly recommended. It is required on the days that they have to be monitored overnight locally. No driving for 48 hours. On the days they're not monitored, they're given their wallet card as suggested or recommended by the manufacturer, and they have that with a 24-hour number to call, and they can go to their local ER and it will tell them what to do. Mosunetuzumab will start Tuesday, Wednesday, or Thursday. The APP will see them on the days the drug is due. Again, this is a weekly ramp up. They don't require post-dose visits. Caregivers strongly recommended. No driving times 24 hours. They're given a wallet card with the 24-hour call number. Again, I mentioned the length of the infusion was a little hurdle that we had to work through, but we were successful in working with infusion. Glofitamab, same thing, starts Tuesday, Wednesday, Thursday. Patients are seen by the APP on the days the drug is due. They stay overnight for cycle 1, day 8. The no driving 48 hours post. They have the wallet card with the call number. We worked with our friends in infusion, got that all worked out. Now, how to manage CRS and ICANS. We had to come up with a plan, Kate did, with what to do during normal business hours, like 7 to 5, and then what happens to them after 5 until 7 the next morning. So, who was responsible for them, since their appointments were not until 1 o'clock in the afternoon. So as the patient care coordinator, they have my number. They have my number, and if I'm off, I roll that to my coworkers. They notify the RN coordinator, notifies the primary hematologist, and the APPs separate they each take a day of the week. So I notify the APP of the day that's handling the bispecific clinic and initiates the treatment per SOP that we have. And I'll show a little bit of that here later on. And all of this is the next part about what the RN coordinator does. That is some internal information that we have, how I trigger an elective admit. Currently, we admit every grade 1 CRS or ICANS. Every one of those is admitted. This is a busy slide, but it just is part of our policy that shows what we do for CRS grade 1, grade 2, grade 3, grade 4, and the management of each of these grades. Also for ICANS, same thing. This is part of the SOP that guides every provider here as to the steps of how to treat this patient. So what do we do after hours? How does the patient get a hold of somebody? How do they know what to do? So working with our hospital at home group, backing up, this is still outside the clinic, but during business hours. This is just a flow chart kind of going over what I spoke about earlier. They notify me, the RN coordinator or someone in my place. I assess them. I can instruct them to take their dexamethasone. That is something very important that the APPs at their teaching and visit, they prescribe dexamethasone 4 milligrams, 2 tablets, and that's like their emergency dose. They don't take it until they're told to by a provider. So if the patient calls me and they're running a fever, 101.4, shaking, chills, I contact the hematologist, the APP of the day. I instruct them to take their dexamethasone, and I tell them where to go. If it's after the OTU has closed for the day, then I would instruct them to go to the emergency room or go to the clinic. It just depends on the time of day and the severity. I coordinate with this. Some of this is internal. I coordinate with the different areas of our hospital as to where they would go. I help them get seen and either be admitted or taken care of until we can get them a hospital bed. So this is after business hours, this slide. This is where hospital at home monitors them. The hospital at home has an emergency telephone number where a nurse is available. They call that hospital at home number. The hospital at home calls the hematology fellow on call. That worked out very well. The hospital at home had a very strict criteria of when to call them and what to say to the heme fellow. During the initiation clinic, the RN coordinator makes visits, assesses the patient, and a big part of my role is educating the patient on what to expect during the ramp up period. As I mentioned earlier, we tried to schedule, say, like Tech and Talc, day 1, 3, and 5. Well, if they had CRS or ICANS or any of that got delayed, I was responsible for coordinating and adjusting all of those future appointments, getting those on the books, making sure the patient and their caregiver knew about those changes. We initiated a flag or a banner that we placed in our electronic medical record that shows up when the chart is opened, that alerts everyone that they are receiving a bispecific drug, because again, it does have very specific side effect profile and treatments for that. I would admit the patient to the hospital at home portal and hook them up to their remote monitoring devices. I communicated with the hospital at home every day regarding the patient's update, if there was anything else that needed to be done. One thing that the coordinator does is once they're complete with their ramp up, I kind of wrap that patient up in a little bow and hand them back to their attending. I schedule their first dose outside of the bispecific clinic, get them back with their provider here at Vanderbilt. And because we have a lot of people that travel from outside our community, from other states or distantly, I work with their local provider to see if they are RIM certified or are willing to take the patient back at cycle 2, day 1. We like to keep all of our patients here at Vanderbilt through cycle 1, even though some of that is outside of the ramp up period. But I coordinate with the local provider and try to get them set up, if possible, to go back home to receive the rest of their doses. Here is an example of our flag that was put into our electronic medical record. I feel like this was very helpful. This is something that we're constantly trying to improve on to make it so that it's seen and that people know what to do with it and know that patients are receiving these types of drugs. I spoke of our remote monitoring equipment. This remote monitoring equipment was really just copied from our CAR-T program. Our CAR-T program here uses this same setup. It looks kind of like an Apple Watch, but they wear it up on their upper arm, and the little wearable device monitors their oxygen, their temperature, their heart rate, respirations, and it goes through a portal that the patient can be monitored 24/7. There is there's the tablet you see on that picture, and the virtual nurse is a Zoom call with the patient to assess them between 10 and midnight. There was also an emergency button that they could push on that tablet that would get them a nurse if they were unable to call. There's also an external blood pressure cuff that connects by Wi-Fi that they would take their blood pressure before their visit with the virtual nurse or anytime they were feeling ill. So discharge from the bispecific clinic, I would message the attending if there's anything special with their follow-up, if they wanted any testing prior to them being seen. I would schedule the next chemo appointments appropriately with the patient's primary clinical team. I would communicate with that provider's nurse what was going on with the patient and communicate with their local provider where we were in their treatment process. All right, and those are my references. That's it. Are there any questions?
Thank you so much, Leslie. That was fantastic. Although I work with you, I actually learned a few things about the glofitamab. We haven't used that one that much. So again, for the audience members here, please, everybody, type in your question in the little chat box you have in your Zoom app. And Leslie and I here, we are also joined by Kate Kennedy, who is our senior nurse practitioner. Thank you, Kate, for joining us. And she has been also instrumental in actually developing many of the SOPs you guys have seen in today's slides and directly involved in the training of all the nurses and nurse practitioners. So let me open the Q&A here. And Leslie, I'm going to ask you a question from the audience member, and of course, Kate, I thank you for being here. You are also allowed to talk. I think I have given you the privileges. So, so we have one question. Especially Leslie, this is for you. This virtual remote monitoring. So you mentioned that patient wears these devices and the app in the patient's iPad, kind of upload the vitals to the portal. But who monitors this portal 24/7? And how we act on the data coming from the portal?
Got it. Their hospital at home has a virtual nurse that monitors that, and their Kate worked with them to set up parameters, baseline parameters, and that is something that we do at first visit. The APP that sees the patient cycle one, day one, enters a note into the chart that has baseline vitals. Like if somebody's always been bradycardia at 52, there's no need for you to call the heme fellow with a heart rate of 52 when that's their normal. But yes, Kate set up those parameters. And when I enroll the patient in the portal, I can adjust those parameters, or we also worked with the company to define those as a bispecific therapy. And it's just a click, but it can be adjusted.
Oh, nice. Okay. And is there a temperature cutoff where patients are instructed to call us? I believe it's 100.4, correct?
That is correct. Or
Now,
hard shaking chills.
okay. Now, one thing I want to clarify is at what level you would manage this patient with just say, okay, take Tylenol and dexamethasone, and at what patient you would say, no, this is something serious, come to the clinic, if it's of course business hours, or go to the emergency room. Can you just give us this two, I would say, patient scenario and walk us through, and it could be any patient you just took care of in the last week or so.
Right, right. So just to note, we have learned through some data collection that we have never had a patient that was found to be in CRS or ICANS through the remote monitoring. They were patient reported or found when they came into clinic. But a patient called after clinic, but during business hours, and they were running a fever of greater than 100.4. Our SOP currently is that all of these people are admitted, grade ones are admitted, and I reached out to Kate. She was my APP of the day. I reached out to Kate and told her what was going on, and she advised me to tell him to take his dexamethasone and his Tylenol and to head towards the hospital. But that's right now, there's zero tolerance. It's all grade ones are admitted.
I see. Yeah, I think, and I want to comment a little bit here because there is definitely a practice variation between our CAR-T team, who has a lot more comfort level with managing grade 1 CRS in outpatient setting. When we have given tocilizumab, for example, in the office, and versus the bispecific clinic, which is, I think we're still a bit extra cautious. And Kate, do you want to add anything here in terms of like actual management of the CRS or ICANS? And it sounds like the remote monitoring, although we are doing it, it hasn't impacted the patient care in a major way. Is that a correct assessment? I'm not sure if your microphone is connected, Kate. Okay. Leslie, you want to comment? Oh, now we lost your voice.
Here I am. Am I back?
Yes.
Okay. Our biggest thing, as far as they've mostly been managed with dexamethasone, and have been, we have only had two patients that have received TOSI, and they were ones that were started. One was started in the bispecific outpatient clinic, and the other one that received TOSI was started before we went outpatient. They were ramped up while they were inpatient. But they're the only two that have received TOSI so far. Most everybody's been managed with dexamethasone.
Okay. So yeah, no, that's very, very helpful, really. And so we have several other questions too. And I think this is a very, very important practical question. This is regarding coordination of the care. So for example, a patient comes to main campus for the ramp up cycle one. At what point that patient get released back to the community oncologist, because we don't like to keep them here. And eventually, if the local doctor is comfortable, our aim is always to transition back to the local. So can you just give us an idea about what level and what sort of communication you will have with the local team?
So we try to keep them here just through cycle one. And I try to make sure that you or the attending get to lay eyes on the patient before they go back to the community. From cycle one, day one, I'm reaching out to their local provider to see if they are RIMS certified, if they're willing to get RIMS certified, what it would take. And some of it depends upon the local provider's level of comfort. Even if they are RIMS certified, but they're new to it, they want them even to, not start till maybe cycle three or whatever they're comfortable with. But we do try to get them back home. It's just so much better for the patient, that they don't have to drive this far. And that has been the biggest thing, I think, really with having the outpatient clinic, and is the patient satisfaction, and then being able to get them back home.
That's just wonderful. That's good to hear. And so you have talked with the patient and the family member, and I'm sure this question comes up, whether you prefer outpatient ramp up versus inpatient. And have you come across anybody who choose to go inpatient for whatever reason?
Yes. We have patients that have chosen to go inpatient. Number one is caregiver situation. You can't drive yourself to or from with talc and tech. You have to have a caregiver 24/7 within the entire period of ramp up. And if they don't have that, or their frailty. And this is another thing, just coming from a nursing aspect, a lot of these patients are older. And so frailty of the patient, during ramp up, sometimes the attending just feels a little bit more comfortable doing these drugs inpatient versus outpatient. But yes, we take all of that into consideration. And there are some that really would prefer to do it outpatient, but we would feel more comfortable with them going inpatient, but
Do we have any parameters where some patient who is about to start bispecific therapy, and if you have like, I don't know, XYZ, it could be like a disease burden or cardiac function or COPD, or I don't know, somebody on dialysis, right? Do we have those set criteria that you're definitely going to the hospital, or you always
no.
default try to do outpatient?
We try to do outpatient and speaking with the attending. If We recently had a provider that had a 90-year-old patient who he just felt better at his cycle one, day 15 EPCOR with them staying overnight. He was just, but he got his first 2 doses, outpatient, but he just felt better, going inpatient for that 24-hour period. So we work with, but there's not a set standard. We don't have a set cutoff.
Okay. So we have a few more additional question here. I think you answered the frailty question, but the one question from the audience member is, how do you onboard a new bispecific? Because as we started the talk, there are actually tens of different types of bispecific in a trial. We have several studies open right now at Vandy. And I do anticipate that many of these drugs will get FDA approved in upcoming years for different disease or indications. So walk me through the process of onboarding a new bispecific, like what goes into the thought process. Is a new SOP for every drug, or you try to look at different drug, like, yeah.
Yep. So that I have that down on one of my hurdles that I wanted to discuss was just how quickly new drugs are being added. just how quickly glow fit, and then we're like, oh, that's a 4 hour infusion minimum, so yes, those have to be made quickly. Kate is wonderful about being able to jump on those quickly and add those into the SOP. I think the most important thing was how was I notified that a new plan was in place? And the pharmacy team worked with our IT team, and it sends me a message basket, and I have my coworkers that are also on that message basket in case something happens and I'm out, so it's not missed. And I reach out to the patient first. I call the patient and kind of talk them through it. That a caregiver is required. Is this going to be a possibility? Lodging. I have thought of many ways to try to get them. I send them a teaching packet. They receive a folder of information that they have at home that includes a calendar, a schedule, and an APP teaching visit is vital. That they have an APP teaching visit before they ever get started with cycle 1, day 1. And it's an hour-long visit where they go through every step, go through their take home medications, their emergency medications. But by either emailing this information to them, the teaching information, or mailing it, they have it at home. If it's a telehealth, or they bring it with them to the clinic, that they have that to go over as the APP is reviewing that. So it's not a surprise, because this is a lot of accountability on the patient and their family as well.
Kate, do you want to comment on onboarding?
Yeah. So I think the onboarding, there's a few different steps. So I think fortunately or unfortunately, nothing moves super fast at Vanderbilt. So we know about a drug and we have a little bit of time before it's really on formulary and available. And in that time, we are working on getting REMS certified. If there's a REMS protocol, we are working on getting everybody educated. So Leslie, all of the APPs, the nurses who are being going to administer it. And then we are also working on getting teaching packets together for the patient. So like right now we have teaching packets for the drugs that we see, like Tectalc, Epcor, Mosin, GlowFit. As we have new ones, we'll have more teaching packets that we need to put together to send out. I think those are the big things. I think for us as an institution, the big thing as we get more of these is going to be space, and how do we, can we stay where we are? Or do we have to find like another spot for us to be? And is an afternoon clinic really the way to do it, or do we need to expand that?
Yeah, so I think that that kind of goes into one of the questions we have from the audience member is like, what are the major barriers? And both of you have been with the program since the beginning, where we were part of the phase 1 Ilrana Tech and Talk study, and then drug become available in the market, and we started doing it inpatient initially, and then we kind of went through this back and forth where to do this. So can you walk us through like the biggest challenges and how you overcome, and what do you see in the future? You touch base a little bit about like as the drug becomes more common and newer drug coming down the pipeline. So training and space, and in a big enterprise like us, we're always fighting for the personnel space and the space resources. So if there's a program which is not as big as us, or with the limited resources, how that can be implemented?
Yeah. So I think that's a twofold question. So I think in a bigger like medical like academic medical center, I think personnel and space is probably less of an issue, but getting things through like politics is the wrong word, but getting things done can be a little bit harder because there's so many different levels of management that things have to go through. I think for us, getting started, getting the right people in the room was the biggest hurdle, and then getting people to agree on how we were going to manage CRS. So I think especially in the beginning, we were managing these patients in the OTU with the transplant attendings, and we were managing them very similarly to CAR T and using TOSI very early, which I think we did not need to do. So kind of moving away from that and getting people comfortable with the idea of moving away from that was tough. So getting that protocol written and or the SOP written rather, and getting people comfortable with that SOP of using DEX and kind of only advancing to TOSI if we needed was one of the bigger hurdles. I think in the community, there's going to be a couple of things that are tough for them because their providers are going to have to be REMS certified, but then their hospitals and whoever's managing them in the hospital are going to have to be REMS certified and familiar. And they're going to have access in some form or fashion to get TOSI if they needed it. And I don't know that they need to have TOSI on hand, but they need to be able to get it. And that I think has been kind of the rate limiting step that we've seen. Like the provider might be, like the oncologist might be REMS certified, but the hospital isn't, or the oncologist is REMS certified, but and the hospital's REMS certified, but the people who are on service, like the hospitalist who is on service for that is not comfortable with it. And I'm not really sure how to help,
Yeah,
I
and
think that's
again,
an ongoing discussion.
it's definitely the RIMS situation in United States is definitely a moving target, and as the drug become more common and easy to use and experience develop, those programs have changed. Like in CAR T, now the RIMS requirements are almost nothing, and I hope that in the future the same happens with the bispecific. And many of the lymphoma bispecific don't have the RIMS program attached to it, so.
Right.
We have, I think, a few last questions. Is any, in your experience, Kate and Leslie, any clinical parameters which predict the risk of CRS in your experience, like tumor burden or some type of comorbidities where you know that this patient is more likely to develop significant toxicity from the bispecific? Have you found a pattern in your practice?
We have not. I think it feels like the patients who have a higher tumor burden are more likely to have CRS, but I think that has been disproven in studies. So I don't think that's actually true. And some people who I feel like are absolutely going to have CRS just fly right through, and then other people don't. I think you just have to be you really have to educate the patient, and you have to be ready for it as the clinician and the nurse. I don't think there is any way to really predict. I know we had been doing like CRPs and ferritins, but those are so nonspecific, and I don't find them to be super helpful. We stopped doing them.
Yeah, no, I agree with you, Kate. In a handful of cases I have done, it's like very random, to be honest.
Yeah.
Leslie, I think this is a question for you because I have seen your Excel sheet where you're tracking every patient and a lot of data you're collecting prospectively. So the question is, what proportion of the patients we have done outpatient setting stayed outpatient throughout ramp up and never went in the hospital? Do you have a rough idea?
You're muted, Leslie.
Thank you. We have treated 31 patients since we have become outpatient, but 2 of those, for frailty reasons, were treated inpatient. So we had 29 that we treated outpatient. We had and saved 92 hospital days by treating them outpatient. And I would have to look at my spreadsheet to tell you.
I think when I've seen it, it's been about 50. I think it's pretty on par with like studies. I think it's been about, of the tech and the talc patients, of the myeloma bispecific patients, it's been about 50% that we've kept out completely. And And then the lymphoma bispecifics, I think we had maybe 2 that went in, but I don't know of how many. But I'm still not convinced that those were CRS. I don't know what those were, but
I think
they did go in during wrap up.
specific, almost none of my patients went in the hospital.
Yeah.
Mhm.
I have done. And so one of the questions / suggestion was, and Kate and Leslie, we kind of discussed this data of prophylactic tocilizumab on the bispecific, and there are now prospective data, of course, suggesting that the risk of CRS can be cut down significantly from around 70% to 15 to 20% if you use a single dose of tocilizumab. And we as a program kind of really looked at our data and our success with the dexamethasone only as a default treatment and prophylaxis pre-medication for these drugs. And we felt that there is no need for prophylactic tocilizumab, at least in our setup here, because we've been quite successful in managing the early stage CRS and with just a dexamethasone. And it's an easy thing. It's an oral drug and patient can take it at their local residence, and tocilizumab being an IV infusion and extremely expensive still. So we choose as a program not to use the prophylactic tocilizumab for the bispecific. And same thing with our outpatient CAR-T program also. We've not been doing the prophylactic toci, but we've been doing prophylactic dexamethasone for our CAR-T for prevention of CRS and eye cancer. I think this should wrap up our session at this point. I want to thank you both, Leslie and Kate, for first of all working on this program and helping many patients and spreading your knowledge and answering all the questions from multiple audience members here. This webinar will be archived on IACH.org website and will be available for any future review. And so after this, if you guys have any questions, it's not that difficult to Google us and email us. So please feel free to reach out if your program has interest in developing this type of practice setup. We're happy to help you guys. Thank you.